Hi, everyone. Welcome back to Misconceptions. This is going to be a special therapist edition. We've done this a few times before, and it's an opportunity for us to, as therapists, as clinicians, to have a conversation with an expert, especially in perinatal trauma or perinatal and reproductive mental health. Today's conversation is with Beth Warren. Beth, thank you for saying yes again, because we just launched, last week, I think it was, our conversation from several months ago. And thank you for being willing to give me another hour of your time.
Oh my gosh, yes. Thanks for having me back for 2.0. I'm glad to be here.
Exactly, exactly. So, for those of you who are not therapists, you're welcome to listen in and get some insider's view into the therapist world when we're looking at the conversation of the presentation of reproductive trauma. So, Beth isn't really an EMDR specialist as well as really a specialist in trauma specifically. So, I want to take it from that attachment lens. That's what we talked about last time. And I just felt like we may have learned about attachment when we were in college or in our master's programs, but I don't remember it feeling like such a tremendous part of our education, right? And it was definitely not something where I was like, this might be at the core of so much of the work that we're doing.
Yeah.
And yet the more I become more specialized and the more knowledge I gain, the more I'm realizing like this is at a core of a lot of the work we do.
Yeah.
I'm hearing it in sex therapy, right? As a sex
Yeah.
therapist, it was such a big part of my supervision. I would say that it was not a big part of my education, but it was a big part of my supervisory experience. So
Yeah.
let's begin. I want to scaffold this. I want to build it from the bottom up. For those of us who maybe aren't as knowledgeable or as experienced in attachment problems, traumas. Let's start with attachment and then we'll build in perinatal. So, where do you want to start?
Oh, yeah. Oh my gosh, we could come at this so many different ways. But I like that you name that. I think in grad school, so many of us get a foundation of learning about attachment theory, attachment styles, and attachment patterns. We often learn about like Bowlby's work, Ainsworth's work, etc. And so we learn about the various attachment styles. And I don't know about you, but for me, my grad school focus really ended there when it comes to
Yes.
attachment work, not necessarily the ripple effects then in terms of intergenerational and transgenerational transmission of patterns. And certainly it didn't, I didn't learn the application in terms of how this shows up with trauma, nor with perinatal trauma. It wasn't until I was doing this work and also, of course, my own work in therapy that I just had such a curiosity in terms of patterns from my how I was parented, how my parents were parented. I mean, it's classic therapists, right? That we are just always so curious about like our stuff and healing our stuff, but then also in perinatal work that we see all of these generational patterns. And then the more I started working in reproductive trauma, seeing how people's parenting styles and attachment styles can show up and inform how they're parenting, and there can be such tenderness and raw spots around
Mm.
trauma as well that can get so activated. So I feel like I answered your question by not answering your question, but I just more wanted to say yes, there's holes in I think our knowledge basis unless you attended a program that has very much an attachment lens, which I know some do, thankfully, and or if you attend a program that has very much a trauma lens, that maybe some of us have gaps of knowledge and are now so hungry for filling in the gaps to focus on what we're seeing in our work and in our offices.
So, when you begin to talk about attachment, I'd like you to discuss and share with the audience about like what are the different kinds of attachment that exist, and which are the ones, especially I think maybe that come up the most, maybe if you can identify that in
Yeah.
perinatal reproductive trauma.
Yeah, absolutely. So when we talk about attachment, it's a huge umbrella term to talk about how a caregiver feels towards their child or baby. as well as how they are actually caretaking their child or baby. And so it's also the bond, how the infant is relating to their caregiver as well. And so when we're talking about attachment work, what we're really talking about is oftentimes twofold. In this perinatal space, we're helping oftentimes parents reflect back to how they were parented and potentially heal any attachment wounds that were there, strengthen any positives or strengths that there were, while simultaneously strengthen their bond to either their growing baby in utero and or their baby postpartum. And so it's multi-layered when we talk about attachment work. It's not just one thing. And so when we're talking about attachment styles, we know that there can be those four attachment styles, which I know is fundamental and kind of elementary for folks. I don't know if we need to really go
I
into
would name
that.
them. I would
Oh,
name
sure,
them for this
sure,
conversation. I would name them because we will
sure.
have people who are not therapists who will be like, I never even heard of this idea.
Yeah. So I want to say just off out the gate that when we talk about attachment styles, there is oftentimes a myth that secure attachment is like A plus and everything else is like ranked and graded. And that's not necessarily the case. And the other myth, and I like that you asked me this the last time we were working together, is what are some myths? Is that it's the idea that if you don't have secure attachment, that it's too late. That's
Mhm.
not the case. We can have earned secure attachment over time. And we also, these aren't fixed styles. They can very much vary, not only over our lifetime trajectory, but also with various people. You can probably imagine certain people in your life that you understandably have to be more guarded, that that they're just not really going to be a safe person for you, even though they're in your life. They're not going to be consistent. That sometimes they are, let's say, cold and or labile and critical and scary, let's say. And other times they're present and they love bomb you, or they're lovely and you're like, wait, versus other people, you can really let your guard down and you really know that they're going to be predictable and show up for you consistently. That
Hmm.
might be an idea if you can have secure attachment with some people and not with others. So secure attachment is a attachment style, which really does mean this idea of I feel safe with you. I know that you are going to show up with predictability, nurturing, guidance, play. We had talked about in our last episode as being a crucial one. And wait, I feel like I'm missing one. Sometimes in the early morning, I'm like, okay,
I know
brain,
it's early
time,
for
time.
you.
So I'm rattling off some key ones, but I'm sure I'm missing. Um, so that's an attachment style. Another one is an anxious attachment style, anxious avoidant also. And that can be the idea of I am preoccupied. I am preoccupied with my caregiver or my person. Even in adulthood, we can have these attachment styles. Hey, what you doing? I'm hyper vigilant. I can read the room like nobody's business. I can read the tone of the room. I recognize when the mood of the room shifts pretty quickly. I can read my partner's jaw when it becomes, tight and tense, or the tone of his or her voice changes. That's that like anxious, preoccupied kind of, I'm continually tuning in, not just because I'm attuned. Oh, attuned was another one from say secure attachment. But that preoccupation with how are they doing from a sense of I don't feel safe. I'm constantly watching, watching, watching.
Mhm.
This might be, for example, when we have a client in our office with us and they're asking us if they are too much. They're checking in with us to see how we're doing. We can see this in our space as well, show up even in our co-regulation and our relational approach. So, attachment style is really interesting that way, in that it shows up in our space, and it's a great way for us to work together as
Hmm.
well.
Hmm.
There can be that disorganized attachment style where someone has consistently had a caregiver who has been consistently inconsistent, and they over time have learned to essentially collapse and not rely on others. And so sometimes they seem engaged, sometimes they seem disengaged. They have learned to not trust others. And so this can be, the hot and cold kind of person, the yearning and wanting to be close, but as soon as there's closeness, pushing somebody away. It can be very confusing to be in relationship with someone who has that disorganized attachment system. And in our sessions, what this can look like is the person who is wanting to come to therapy, often is coming to therapy, might be canceling sessions, or the yes butting, that won't work for me. I don't want to do that, but yet is really hungry for help, is seeking out help, is suffering. That can be an example of that. And then what did I not name? Avoidant. The avoidant attachment style can again be cultivated over time. That's probably not the right word, with a caregiver who has not shown up for this
Hmm.
person, and this person has just learned how to shut down and just be there on their own. And so you might see, like I said, this idea of different attachment styles with different people, different relationships. It's not always an all or nothing thing.
And it seems like it's something also that has these kind of four kinds of attachment also have quite a bit of overlap,
Yes,
right? You could see how we can have the anxious avoidant, and we can have,
yes,
I hear how disorganized and avoidant have a lot of similarities as
yeah,
well,
yeah.
right? And so when you, as a therapist, when you're, I'd love to bring in the perinatal piece of this now, or the reproductive trauma piece of it. So there's an event that happens in a person's life, in a woman's life, where she is, experiences something significant at a birth. And I want to go with like significant. So it would be something like, again, not to discharge any small t kinds of traumas, but there's an event at a birth or as a part of the pregnancy. It could be something like a significant illness in pregnancy, or a hyperemesis. It could be something like something, where her life is at threat, actually. Or it could be something like the woman experiences a very severe injury at the birth, and they're not even sure she's going to ever have more children. These events that are cataclysmic in nature, that happened at the time of the birth. And when we're thinking about these different, we think about that as a reproductive trauma. When you put on your attachment hat, when we look at these four kinds of attachment, and maybe this isn't how you perceive your case or your clinical perspective, but like when I think about somebody who comes to me with any one of these four, how might that present to me when working with somebody who has a birth trauma? Does that make sense?
Oh, yeah, yeah, yeah.
Okay.
Yeah, I mean, how we are parented very much can inform how we then parent. I mean, period. We've seen that in attachment theory work and research since the beginning, in the 50s,
Sure.
60s, 70s, and beyond. And that's without even layering on the layer of trauma, but especially when there's then this piling on of various issues such as trauma. And so think about someone, let's say, with that anxious preoccupation, with that style of hypervigilance already. And then there is a traumatic event. No wonder why there might already then be this hypervigilance towards focusing on the baby, checking baby throughout the night, worrying that they're not doing enough, or maybe even continuing to check in with the partner. I feel like I'm failing. I feel like I'm not doing a good enough job, not only as a mother, but also with you as a partner. Are you upset at me? Are you mad at me? Etc. Those things that already were brewing, those things that were already a continual struggle, will just become that much more amplified when you are in survival mode, when your
Hmm.
nervous system is so activated. As we know, it can be really hard to think rationally and respond from a logical physical space, but it's also hard to connect. When we're in survival mode, you're not in the brain space to connect from a calm space. And so
Hmm.
that's much more activated. And so understandably, some of those attachment fissures and wounds can and just get amplified and amplified. Or if someone, let's say, has that kind of avoidant tendency, that we might see more of a collapse or that much more difficulty in attaching to their baby, or might misperceive the baby as not liking them or preferring their parent, or I got a quote, bad baby, misperceiving a baby's cry. And I'm giving extreme examples here, but these are the things that we kind of hear. And so, I'm not working with clients with labels in terms of like, oh, this person has, an anxious, preoccupied attachment style, but certainly I'm just kind of exploring themes, trying to explore what already they might have, how already they might have approached relationships in their life, what already might have been strengths of theirs and struggles of theirs, and then how this might have become amplified. What feels normal for them and what is now not normal for them? How do they feel off?
But what's interesting to me is as I hear you describing it, I also hear what I think would maybe initially be labeled under the realm of OCD, right? So that intrusive
Yes,
thought.
yes,
Maybe the
yes.
baby doesn't like me. Maybe am I doing a good enough job as a parent? Maybe I
Yep.
didn't do enough to keep my baby safe, checking in on the baby. So like it's interesting to me to be like, are we hearing this from are we visualizing, are we conceptualizing the case, if we have to call it a case? Are we conceptualizing this story from a perspective of, well, this sounds like OCD and we should treat this as postpartum OCD or perinatal OCD? Or are we conceptualizing it from the perspective of, well, this is actually attachment wounding and we're going to take this from an attachment perspective. Like this is an attachment wound
Yeah.
and the way they see the world is like that. And but if we help them reorient to safety or and I guess that becomes a question, like it becomes the question, the job of the therapist at that time. But are these two separate things or they're just deeply integrated? It's just a matter of what lens or which pair of eyeglasses you put on.
Yeah. Oh my gosh. That is, I think, the $1 million question, because research, as well as just anecdotal evidence in our practice, we know that attachment is informed by a parent's mental health as well as their attachment style.
Okay.
Excuse me. So, oftentimes, what we'll see is by addressing the mental health symptoms, the attachment will spontaneously on its own start to improve. Or we might need to do just a little bit of jiggling and, teaching them some attachment skills or helping do some prompting in terms of like, whatever it is, like helping them face the baby towards them or pointing out what they are doing really well, or just saying, oh gosh, like I know you're coming down hard on yourself, but I can't help but notice how you just handle that diaper like a champ, or whatever it is. I don't know,
Right.
those are
Right.
silly examples, but
Right. No,
but
good ones.
you're
Right.
I love that you're recognizing that there are so many Venn diagram overlaps here, that we aren't just going to approach this one way. We're going to be thinking about this in such a nuanced, multifaceted approach that, yes, very much the parents' mental health symptoms will be showing up as well as their attachment styles. We're not going
Hmm.
to be working with attachment in a vacuum, in other words.
Hmm.
So
Hmm.
their mental health symptoms are showing up in the room. They're all the stressors that they're dealing with
Sure.
environmentally, their lack of resources, their lack of support, what's going on sociopolitically, what's going on in their life, all that they're holding. So in other words, we're dealing with all of those things. Sometimes I just really marvel, by the way, as an aside, but not really an aside. What we do as perinatal mental health therapists is the coolest. It really is such an honor to do this work, but it's also a big deal. We are
Hmm.
juggling so many things while also sitting very calmly,
Sure, of course.
holding space.
Right.
But in our heads are like the beautiful mind guy, like pew, 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 like
Right.
writing all this stuff on the window. We are managing so much, thinking about all these various intersecting factors.
Would you say that? when when I think about this OCD attachment overlap, if you were to treat this, if we see this through the lens of OCD and it's treated through the lens of OCD, if it may be exposures, if it may be medication, which we very often really do recommend kind
Yeah.
of right off the bat for somebody who has significant
Yeah.
OCD or even distressing, moments of significant distress with their OCD. Um, do we then see them able to attach more effectively, or then all their difficulty in attachment is still there? Like the OCD might be quieter, but the attachment might, is it like kind of like reveal itself differently once we treat the OCD?
Yeah, it's TBD. To be determined. It's like really, it's a case by case experience.
Right.
And that's why I say it's not all or nothing. So let's use your example of working with someone with perinatal OCD. If we assess and determine this is at an OCD level, and we really start down the path of treating the OCD, let's say we're doing exposure and response prevention, we're really helping them start to learn to drop some of their safety behaviors, they start on medication, etc., that it still might not be an all or nothing thing. Maybe as we're doing that, we're also noticing that they're still having difficulty in connecting with their baby. Yes, we're doing this crucial ERP work, but they're still having difficulty just in connecting. And so we might be encouraging and we interweaving some attachment work there too. Or as
Okay.
they're talking with you and as you're doing this work, they're also able to reflect back and notice, oh my gosh, you know what I'm realizing, because this is actually quite common. Um, I've probably had this my whole life.
Hmm.
I probably have had some of these symptoms of OCD starting back to when I was a kid after this traumatic thing, and starting to recognize maybe some themes from how they were parented. So we might start interweaving more of a larger treatment plan that once the OCD symptoms start quieting down, that maybe we'll start bringing in some deeper trauma work to process some of their past, or bringing in some attachment work, attachment repair once the OCD is quieted. Because what you're talking about is crucial, that when a client's or a parent's mental health symptoms are so activated and intense, whether it's PTSD, OCD, bipolar, whatever the perinatal activation is, it's very common to lack discernment. It's common to lack discernment in that relationship and bond with their baby. And so, as I mentioned, sometimes just treating the mental health symptoms alone will be enough for the connection with their baby to start to feel more solid and natural for them, the confidence to start building for them to be able to tune into their baby and build that attunement and connection. For some, it still is quite difficult because maybe they lacked the modeling growing up,
Hmm. Hmm.
or there are deeper threads to pull on. Does that make sense?
So the thing that I'm like trying to split a hair on, which tell me if I'm
Sure.
just trying to split a hair, but
No.
what I'm hearing, which I think is new to me, is this idea of like when I'm hearing it as if somebody has disorganized, or let's say the anxious attachment. Okay, this is their attachment pattern from childhood, that it is possible that somebody with that anxious attachment feature of how they see the world around them may actually accelerate into OCD level diagnosis, meaning you have somebody who sees the world as a checking, looking, always watching, always kind of perceiving others around them and maybe getting really stuck on that. And that if that is the way they see the world, that in an acceleration of that, it could actually reach the level of OCD. Is that accurate? Am I saying that properly? I know you say it's like according to very specific cases, but it's an interesting way of seeing it as like OCD can be a manifestation
Mhm.
of perhaps a manifestation of the way we see the world relationally
Mhm.
because of the way that we were raised or because of the way that we were parented. Is that accurate, or did I split the hair wrong?
I don't think you split the hair wrong at all. I think it's such an interesting thing to be curious about, because we know that OCD and trauma are very much overlapping, and um, not just comorbidity, but the chance of having OCD is that much more amplified or higher when you have had trauma in your background. And so think about what some of these attachment styles are from is I wouldn't go so far as to say trauma, but let's say when you have had situations in which you have been unsafe.
Right.
So, when you have had a parent that has been volatile, angry, has had addiction, is abusive, neglectful, and you have had in a very sophisticated way to build this self-protective system of a heightened radar. I am going to be, and never conscious, of course, but this little child who has learned to be hypervigilant, on high alert, knowing how to read the room very quickly, knowing how to read an adult's, mood, and knowing how to read an adult's, even a walk, or, how the garage door slams, whether that's just the normal slam or whether that's, oh, dad's angry slam. I gotta hide. I gotta now be the good kid. I gotta be the complacent, quiet child, etc. So yeah, I think you're making a really good point that
Hmm. Hmm.
um, I, I
And
don't
I would move it into one more sentence. I need to be safe. I need to keep
need to
myself
be
safe, right?
safe.
That door
Yeah,
slams. My reactivity to that would be, am I safe? Do I need to do something to stay safe? If you take that into that parenting model, right, where I'm now parenting a newborn, I need to, I mean, OCD, I think we all see it as like, I need to make sure that you're safe. I'm in charge of seeing of this newborn baby, and there's so
yeah,
much threat everywhere.
yeah,
And it almost like feels like an acceleration of I'm now in charge of keeping this little person safe. And my thoughts are on fire all the time about all the threats in the world around you. It could be
yeah,
contamination. It could be, threat of all the bad things that are happening on my block, in my neighborhood, right? Like that constant thinking of, or I'm not doing a good enough job as a parent, right? I'm
yes,
not, I just had a conversation with a mother who said, I already feel like I'm failing, and the baby is all of several weeks old. Like that is such
yes,
a fast transition from I'm so excited and hopeful to I already feel like I'm already not doing a good job. And the thing that was the greatest concern was whether, she was not doing enough tummy time, right? Like, or
yeah,
like not reading the baby books or things like that, meaning
yeah,
this expression of like the things that other maybe more securely attached women might be like, you're fine, to I'm not fine because it feels like there's risk here, and I'm supposed to keep this child safe, and I don't know if I'm doing it safe and healthy maybe, and I
yeah.
don't have the ability to do that, or I'm scared, or I
Or
don't have,
the
yeah,
those thoughts are fleeting, right? Because who doesn't have those thoughts at some point as
sure,
a parent of like, well, I totally screwed that up, or like, man, I suck, or that was my worst moment. But those are fleeting thoughts and they go versus catastrophize into
mm-hmm,
it's not just what I've done, it's who I am.
mm-hmm,
I am a bad parent. I am a bad mom. I am a failure. So,
mm-hmm,
yeah, that's where we see the intersection of mental health symptoms plus those attachment styles. And so to circle back to what we're talking about is that sometimes we see just the work that we're doing around treating the mental health symptoms is the work, is enough to help alleviate any of that distress around the connection and bond with their baby. And then sometimes it's not. Sometimes in doing that work, we see a bit of a relief, but there still remains this persistent and maybe even characterological negative core beliefs that then we can work on doing the deeper attachment
mm-hmm,
work. So
mm-hmm,
this is where this work is really important, is that you can kind of think of these as like clinical crossroads moments of like what would take priority, where's triage, what are we going to first start with, what's the easiest thing to start with, and it's
mm-hmm.
typically treating the mental health. It's typically starting with the most prioritization, but also the easiest, quote unquote, to treat.
Right. The
And
putting out the
then
fire also
putting out
sometimes,
fire.
right,
And then
right,
where might we go to next? Because
right,
I mentioned this on our last podcast, is rarely are people coming in the perinatal space saying like, I want to work on my deep attachment wounds or stuff from childhood. No, it's like the immediate distress, it's the immediate difficulties, it's the immediate challenges around parenting, or
sure,
what, or their traumatic birth, or their distress around infertility, or whatever it is. It's usually the attachment work that they then are staying in therapy for,
sure,
that we're
right.
doing the work later.
So when we introduce, so come to it, let's say from we'll go with the dysfunction versus a function, but let's say coming to it from a disorganized or an anxious attachment style perspective. And then there's this event at a birth that's a trauma.
Yeah.
How does that show up? How does it get like kind of intermingled with attachment style when dealing with the baby, when also dealing with the event that happened to them? What is the narrative you're hearing?
Yeah. So, you know how already with reproductive trauma, we hear negative self-beliefs showing up. We hear this negative narrative of, I'm a failure, or I did something wrong. I should have chose differently. There's constantly this negative narrative that is happening. It's not just, of course, being held in the body and these somatic flashbacks and this intrusive thoughts and memories and stuff, but there's this continual negative narrative throughout. That's often where we can just be very observant and ask some additional questions in terms of, is this a repetitive or familiar voice for them? Like if they're saying that they're a failure, or if they failed to meet expectations, or even if they felt powerless, etc., or out of control, is this something that is familiar to them? Is this something that they've experienced before? Because this is where we're going to be curious in terms of, has this shown up for them in the past, not just in terms of lived experiences, but maybe also in terms of their interactions with others. So we're not going to be jumping to the conclusion that this is an attachment style right away, because that's going to take time to explore, but maybe just like exploring with curiosity. Is
Mhm.
this that they've had other traumatic incidents, that's how their brain has internalized these experiences, and or is this also maybe how they have learned to experience others in their lives?
And so when, let's say, for example, somebody with a disorganized attachment,
Yeah.
what might the narrative, obviously without assuming it, but what might the narrative sound like if you have experienced a reproductive trauma, a birth trauma? What might that sound like when they have this history of the way they perceive the world in what we would call the disorganized attachment lens?
Yeah, and it can get really tricky because, as we know with reproductive trauma, there is so much truth in what someone is often saying to
Right.
themselves, and it can often become distorted with self-referencing beliefs. So, what I mean by that is we might hear someone say something like, I can't trust others. My provider let me down. I can't trust others. And then it might go to, I can't trust anyone.
Mhm.
And so we might have heard this pervasive betrayal from others in their past that then is reinforced by, let's say, harm from a provider. If they had, let's say, obstetric violence or even just a negative experience with a provider. And so that's what I mean in terms of, this is true. This isn't amplified. This is not distorted in terms of where it starts. Like, I have been betrayed, I've been let down, I can't trust. What can become really sticky is when we start to hear this across the board,
Mm.
broad sweeping statements of, I can't trust anyone, I can't trust any provider, I can't, everyone lets me down, everyone in my life. We start hearing these broad sweeping statements. It's very similar to those of us who work with survivors of sexual assault, where we'll start to hear these things, maybe initially, or maybe even years down the road. I can't trust men. No man is safe. All men are, fill in the
Mhm.
blanks. And that can be so common after a traumatic event of this type of, it's like the pendulum swings the other way in terms
Right.
of self-protection goes to these um,
Like more extreme
extremes.
perspectives. Yeah. Yeah.
Yeah. And so when you already have this attachment style of like, no, but for reals, I can't trust, I can't trust, I can't trust, I can't trust. And then here's one more person, especially someone in a power position over you that has let you down, that it can become that much more amplified.
Yeah, and I also remind myself that we are also in those positions of power, right? As
Yes,
a
we
therapist,
are.
like we still, so when they say I can't trust anybody, by the way, you're in the pile. Like you are
Yes,
included in that conversation, and there's
yes,
no amount of reassurance or convincing safety. There's the
yeah,
reassurance is useless. So,
yes.
I'd like to move this conversation into treatment to talk about, like, we kind of set up the conversation a bit about how different attachment styles will respond to a traumatic event and kind of, in some ways, maybe even replaying out or kind of continuing that thread, as you say, that thread of from a more complex parenting experience in childhood, how we learn how to be safe or not so feel safe in the world. What does treatment, where do you personally begin the treatment process with your clients?
I know this is the most annoying answer, but it depends.
It depends.
It really depends.
We're going to call this podcast, well, it depends.
It depends. The end. What if that was all I said? I do want to just say it is always based on self, though. It's always the relationship and the relational approach. That co-regulation is really crucial when we have a client who has either had attachment wounds and developmental trauma from childhood and or reproductive trauma when they're walking in such an activated space, nervous system dysregulation, and just plain not feeling safe, or they've had personal harm from a provider and or have experienced historical harm. Let's say they're a person from a marginalized community, etc. It is so important that we're approaching this work, to your point, what you just said, in a very gentle way, and recognizing that we go slowly and very much client-centered based on what they're needing. And so that's what I mean, that it depends. It's really
Mhm.
going to depend on how they are coming to this space. If they are highly activated, maybe we're going low and slow and gently. If they are, maybe more, if they're presenting with disassociation or even more guardedness, that maybe we're going to do different techniques to be able to draw them out in a gentle way and sit with them. And it's also, frankly, based on their goals. So
Sure.
even if we're seeing attachment threads, but they are wanting to talk about their birth, work on their birth, that, we can help kind of gently pull out themes and with curiosity ask some questions, but it's also honoring what they're wanting to work on, and honoring agency and choice, because that has just very much gotten stripped from them, not
Yeah. And
feeling
I love,
worthwhile.
I love what you're saying, because I think sometimes I think we come in with a little bit of an agenda, especially maybe we just took a
Yes,
training and we're like, oh, I'm
yes,
going to take this into training, and oh, this is
yeah,
how I'm going to, all of a sudden, all my clients I can apply that training to. Like, not so much. But I think when you talk about like approaching with curiosity and beginning to pull at threads, I think one of the things that I think is an important thing to remember as therapists is this idea of you don't have to jump into the expert role. Like, you can sit
yes,
in the observer role a little bit more and trust
yeah,
that with time, as the relationship with the client kind of develops a little bit more safely, then you'll be able to use your like expertise and therapist-y language in order to more, kind of to lean on your expertise a little bit more than you're leaning on your relational experience. But the relational experience is the work. I had a therapist recently, actually did some consultation with Hillary Waller. I'll name her right there. She was
ooh,
working in the postpartum stress center here with Karen Kleinman for many, many years. And she's
yeah,
actually the co-author of her most recent book. And Hillary
yeah,
said to me, she's like, your relationship with your client is the resourcing. That was
it
really
is,
very powerful for me as an EMDR trained therapist who has a very complex relationship with the EMDR. Is that when I kept looking for that other thing that was going to help the client ground, and she kept reminding me, no, the way you are a relational therapist, I work very, I believe that I develop good, strong relationships, safe relationships with my clients. And that's the resourcing. You don't
yeah,
have to like make a box and send it to the garage. Like, you don't have to, like, in your mind, right? You don't have to send them to ComSpace. Like, that might be the relational experience of client to therapist, therapist to client is grounding to the client if you've done it well. And that really helped me understand a little bit more about what it means to be a therapist, about what it means to use that skill. And I think sometimes with modality training, we lose the relationship piece. We lose the emphasis on the relationship piece. Do you feel the same? Do you see that happening in the world? Like, people always ask me in consultation, what modality should I train? And I'm like, how about you just try to be a good therapist first? Like,
yeah,
just start there,
yeah.
right?
Yeah, and both things can be true that it's important to learn these modalities that are really effective, but we can't lose sight of us as the clinician, and that relational approach has to be the foundation. It absolutely has to be. It has to be when we're working with people with trauma. It has to be when we're working with people in the perinatal field. I mean, this sounds cheesy, but I'm going to say it anyway. We are holding our clients as they are learning how to hold their babies. And of
Mm.
course, I'm talking figuratively, maybe literally for them, but like it is very much helping them um, learn to do that and earn secure attachment. For some of our clients, this might be literally the only space that they've been able
Yes.
to share their story without having someone jump in with a minimizing message or an invalidating message. For some people, this might be literally the only safe space, the only
Yep.
place where they've been able to come and just be.
Yeah.
This might be literally the only space where they've been able to have it just be about them for an hour, the only space where their nervous system feels regulated, where they're able to emote and not have anyone, try to stop their
Fix it.
emotion
Mm-hmm.
or fix it,
Mm-hmm.
etc. And
Mm-hmm.
so they also can start to learn a different type of relationship as well, where there can be that unconditional positive regard, where there can be that safety and that predictability and that nurturing, etc. And it's almost like a learning lab where then they can go and start to apply these same experiences. And there can also be rupture and repair. There is not an expectation that we get it perfect as therapists. Of course, we're going to do our best to not cause harm. But when we do that, then we repair, because again, for some of our clients, this might be the first time that they've had someone own and take responsibility for harm that was caused, repair and reach out and try to do better, etc. So all those
Yeah.
things. Yes,
Yeah.
the relational approach is everything. And especially when we're doing attachment work, it has to start there.
Well, I think what you've done is really brought this full circle that if I see this through an attachment lens, I see much of my relationship with if I see the dysfunctional attachment that might be presenting in session or the challenged attachment, then when I learn to, or when I model safe and healthy, perhaps secure attachment, then what I'm doing is really that's where the change is actually beginning to happen. It's
Yes.
not only about talking about it and helping them understand it and helping them how they see the world, it's actually beginning to create an example of what secure attachment can feel like for our clients.
Yeah.
And that might be the first or newer experience in their maybe the first time in their lives where they begin to see what it feels like, everything you just described, so that I might see it through an attachment lens. They just see it as like, this is a person I could trust. This is somebody
Yes.
who's showing me how to do this right.
Yeah, and I love what you said before. I forget your exact words, but it's not like we're going to go all academic on them, or we might not even be
Therapist-y.
therapist-y. We might not even be naming some of these things. It's
Mm-hmm.
not like we're holding up a
Correct.
sign to be like, this is now attachment work. But sometimes we're even doing our own self-regulation in order to be able to tolerate their emotions and big feelings so that then they are able to tolerate their babies. And so it's just this continual like co-regulation
Mm.
aspect and holding space. So yeah, it's that attunement, that building of attachment is really
Mm-hmm.
beautiful work. But yeah, that's why I say it depends. And so, for example, in terms of like where to start, I personally don't give attachment screenings in electronically or in paper. I find that there often is a lot of shame with so many parents anyway, walking in the door, feeling less than as parents, feeling like they've
Sure.
done something wrong. I just tend to interweave some of those questionnaire questions in our work organically. So as it might come up, if a parent's saying like, oh my gosh, I'm such a bad mom, or I feel like I've failed, or to your example of someone saying because they're not doing enough tummy time, feeling like I'm blowing it completely. I feel like I've totally failed. To ask a little bit more questions about that. Where else is this showing up? How else are you talking to yourself
Mm-hmm.
that way?
Mm-hmm.
And then maybe asking some opposites. Where might you feel like you are doing okay? Where do you feel like even just the care for your baby is something that you are, okay, I've got a little bit of this down. I'm
I'm just noticing also, you're not saying to them, you're doing a great job. I'm seeing you doing a good job. You're saying, where else is it showing up and where are you noticing that you're succeeding? So, which I think is so critical. I once heard, I once had advice from somebody when I had very young children, where somebody said to me, instead of saying, "Mommy's so proud of you," to say, "Aren't you proud of yourself? Like, do you
Mm,
feel proud about what you just accomplished?" Versus it being
mm,
about "Mom is proud of you," right? Or
mm.
there are moments to say we are very proud of you, but then there's
Yeah.
more moments to say, "How do you feel about what you just
Yes.
accomplished? How do you feel about what you
Yes.
just succeeded in?" And I think that that's similar to this perspective of like, instead of telling them you're doing a great job, which can be reassurance, which when you have OCD, by the way, that could be just reassurance seeking, right?
Yes.
But if you help them begin to cultivate that other voice in their head that is one of, I am doing a good job or a good enough job, or feeling the security of the relationship between parent and child, then that has much wider, broader impact.
Yes.
Um, One thing I wanted to do before we wrap it up, I want to talk. You mentioned that there were some techniques that you might have if you notice that somebody is dissociative or is just having a hard time or testing the relationship perhaps because of their history. Maybe you want to offer one or two techniques that you use. I know you are a very skilled EMDR therapist, but maybe offering some techniques for those of us who are not yet EMDR trained, or just, what are the things that you like to use? I feel like we're leaning more and more into the somatic space.
Yes.
But could you offer something that would be a clinical takeaway?
Sure. The somatic is so crucial when we're talking about trauma in general, but especially reproductive trauma, because think about how in reproductive trauma, the body is so involved, and the body then continues to hold and experience the trauma afterwards. And so we're not able to talk ourselves out of trauma as much as we try to, as much as we try to reason ourselves out of it, talk ourselves through it. That's why so many people after a traumatic birth, for example, or even as they're going through a high risk pregnancy or infertility loss, continue to try to tell their story, continue to try to find meaning, and might find that that's really frustrating to them because they might keep getting activated, or they might find there's a particular part that is just so tender that then it's hard to articulate, or maybe they avoid talking about it altogether because they say, I don't even trust myself without losing it. And so sometimes it's that we might even just ask them as they're trying to talk about it, what are you feeling right now in your body? What's coming up for you? Or even being able to point it out. I noticed as you were just sharing that particular part that your shoulders really started to tense up, or I noticed something shift right then in your body. What do you think came up? What just happened? So sometimes it's as simple as that, just even trying to name what happened or helping them name it, because sometimes they're not really consciously aware of what just happened with their body. For a client who's pregnant, let's say after a loss, because this is so challenging to feel safe in one's body afterwards, understandably, or even after a prior birth trauma, reproductive trauma, sometimes it's same thing, just helping them take little sips and experience being in their body in little bits. We might do the same thing in our office. Same thing with postpartum, and trying to safely tune into or inhabit their body, or maybe even connect with their baby. It's always just like taking little sips, doing things little bits at a time. So, for example, a lot of our survivors of birth trauma find that like wearing their baby might feel really intolerable. A lot of people say it feels suffocating, like it's too much touch, too much closeness. And so we might even just practice with them just holding their baby against their skin for maybe 20 seconds at a time while their baby is calm. Of course, we want to build them up for success while we're speaking in a soothing tone, coaching them through it, praising them for it, something like that, or even doing like a walk and talk so that we're right there next to them. Recognizing, how does this feel? Look at you being able to do this. I know this is hard. What's going on in your mind? What's going on in your body? So all of these sound very simple, but they're actually quite powerful when a person has learned how to disconnect and potentially even fully disassociate from their body out of self-protection.
Mm,
And the same thing might even be happening with their baby as well. There might be overwhelm with touch. There might be overwhelm with their baby's cry. So we might just be slowly helping them tune in and
mhm.
regulate themselves.
So powerful. And I think, again, like being that safe person in the room with them, virtually or otherwise, like being in that safe room and that safe supported space, they could become the dysregulated person and then learn how to regulate. And you are the person who is safe and stable and secure, their
Yeah,
grounded, safe base that they maybe didn't have before, but can begin to use you in that way that they, maybe didn't have in childhood, but you become that safe base, which I
yeah.
think is super powerful. So, what a conversation. So much to think about, so much to learn. I feel like I don't know about you, but sometimes I feel like, could I just go to school all over again? Could we just like start again from the beginning with
Yes.
all the knowledge I have now? Could we just like do it again?
Yeah, I feel
So,
the
yeah,
exact same way because now I would be so much more choosy about which classes I took.
totally.
Plus, I feel like
Yes.
there's so much better offerings
I
now.
agree. I agree
Yeah,
completely. And then somehow we end up becoming the ones that are just teaching those classes instead
yeah,
of taking them.
totally. Oh my gosh, that's exactly it. I have so much more hunger and there's so much still more to learn. I don't care how
Yeah,
long I'm in this field, I'm still like a baby
always.
when it comes to the things I want to learn.
So much, so much. So thank you for teaching and for being so present
Thank
with me in this
you.
conversation. I know that it will help our therapists learn and grow. So thank you so
Thank you.
much.
Thanks for having me.